रिपीट कर देता हूँ। औज़ु बिल्लाहि मिनश शैतानिर रजीम, बिस्मिल्लाहिर रहमानिर रहीम, इन्ना आतैनाकल कौसर फसल्लि लिरब्बिका वन्हर, इन्ना शानिअका हुवल अबतर। सदक़ल्लाहुल अज़ीम।
आमीन।
जज़ाकल्लाह। आज का सेशन हमने आईटी से रिलेटेड किया है और आईटी के इम्पोर्टेंस स्पेशली ड्यूरिंग द कोविड एरा कि हमने उसको 3 हिस्सों में इसको तकसीम किया है टुडे सेशन में। और पहले सेशन में हेल्थ केयर, इलेक्ट्रॉनिक मेडिकल रिकॉर्ड, इलेक्ट्रॉनिक हेल्थ रिकॉर्ड और डाटा इन द हेल्थ केयर सिस्टम, जीनोमिक्स, और उसके बाद that will be followed as most of our sessions, colleges were due to lockdown were closed and our sessions were online. इसके बाद होगा तो यूज ऑफ आईटी इन द मेडिकल एजुकेशन, और फिर आजकल जो पिछला सेशन था टेलीमेडिसिन के अंदर बहुत सारे सवालात थे कि जी स्टेथोस्कोप ना हो तो हम कैसे पेशेंट को मलेशिया में बैठ के चेक किया जा सकता है। Dr. Mubbashir Iftikhar is the son of Pakistan. He graduated from the Punjab Medical College, PMC. Now it is the university in 2000. But entirely adopted the different field of IT, use of IT, information technology. He is highly graduate and highly expert in the Malaysia. He is at the highest post in the Malaysia. Remaining introduction, I am handing over this session to the Dr. Mubbashir Iftikhar. Dr. Mubbashir Iftikhar, you are host now, or now it is over to you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much to Professor Mulazim Hussain Bukhari Sahib and all the other attendees, participants, and to the PMA especially, and the both medical colleges who have organized this. I'm really thankful for giving this time and honored to present some of the thoughts about the IT. Before I would start, I would like to acknowledge the incredible contributions of the healthcare professionals in response to COVID in Pakistan and world around. Gratitude and salams to all of them for their hard work and great work. So basically, I'm a graduate of PMC Faisalabad. In 1996, I graduated and worked at JPMC for a year in Karachi, and then in year 2000 I started working at emergency department in HUKM Hospital, University Kebangsaan, Malaysia. In 2004 I joined Department of Surgery to start my master's in surgery, which I left in third year to start my passion for IT. Ever since I'm in healthcare IT, though I have always worked in healthcare, but in the medical, rather than dislocated from medical fraternity or disjointed and then relocated into the healthcare IT. Now I say actually it's the privilege to work in a healthcare IT. So started with medical tourism in healthcare IT in 2007, then worked as three and a half years to run my own passion, a company locally, then joined as CIO, Chief Information Officer at the largest private healthcare provider in Malaysia called KPJ Healthcare, which I worked as CIO for almost 6 years. And I took a lot of projects. Like when I started, they don't have any cloud computing solutions. So I started the first of its kind in Malaysia, where I brought a complete hospital in 2012 into the cloud with both the clinical application and the financial application. So means the cloud was located in a remote location. Then the hospital was in another state and the cloud was in another state. And they were all doing work almost in real time, entering patient data, entering financial data of the hospital in the cloud in 2007. Launched a patient portal, personal health record. I was selected as CIO of the year in 2013. And that was a great achievement for a medical doctor to be the year's best CIO in Malaysia and at ASEAN level with one Singaporean. So Frost & Sullivan also picked my cloud related project as the leading cloud enablement project in Malaysia for running a hospital in the cloud in 2015. I played leading role, visited almost like Europe, US, all big IT houses, Facebook, Google, Microsoft, Hewlett Packard, IBM. I visited them in different years and had like a personal meeting with their bosses. And then I worked on electronic medical record adoption. And then at the utilization, when I started, KPG Healthcare was less than 50% for outpatient and less than 20% for inpatient, which when I left as a CIO were more than 90% for outpatient and more than 70% for more than 65 to 70% in inpatient. Then we had there is a HIMSS model of adoption of EMR, we call it MRAM, electronic medical record adoption model, and we achieved 5.6 for a self-developed EMR, which was a great success. And there are actually from level 1 till level 7, and we achieved level 5.6 saving. And then we conducted a study to see what is the benefit of using EMR from financial standpoint. And Ernst & Young conducted a study with me in one of the hospital, and we saw that we saved 6.7 million in year 1, or in that particular year of utilization rate of a 39%. So we could say like we have more higher utilization, we can save more money. And this was how we like digitalizing rather than using paper records, speed of delivery of healthcare, reduction in errors through the electronic medical records, safety and improvement in providing care, and then reduction in wastage. All of these basically resulted at the 6.7 million at the hospital level. Then in 2016, I was the Chief Digital Transformation Officer, Digital Transformation Head for 1,400 doctors, mostly medical specialists, and about 28 hospitals. I was the head of the digital transformation for KPG Healthcare, where I worked for 2.5 years and left to like explore newer areas into the technology, which I'm currently doing. I launched as being head of digital transformation. I launched Ibm Watson for oncology, first of its instance in this region. India had earlier launched it. Singapore had a different area in it. Thailand had Ibm Watson for oncology, one of the earliest one, but in Malaysia, we were the first ones. And I was at the launch of the Ibm Watson at the Astor Building, New York in 2014. I was the only Malaysian and probably one of the 50th persons in the world who were selected to witness the launch. And I was sitting right behind with the scientists of Ibm Watson at their headquarters, IBM's headquarters in New York. Worked as, during my work as digital transformation head, I launched social media in healthcare, like what are the intricacies, importances, because social media is seen as like against like how you share the medical record, medical knowledge in those days. It was a bit quirky and technical how to do it nicely. Then digital marketing, patient-centric approaches, worked on many of those initiatives within the KPG Healthcare. Then I basically went to join the startup, which I had initially started in 2007, and then worked on a new EMR, worked in medical education, which I'll share, and digitalization with a lot of companies, my IT companies, helping companies from around the world in like web designing, web development, software development. We have offices in Karachi and offices in Kuala Lumpur. My first part is about healthcare IT. So basically, I start with the EMR, EHR, electronic medical record and electronic health record. Earlier, it was electronic medical record. Later, the term was coined as electronic health record. And basically, it is like how we enter patient data. Difference between them is EHR is a wider system where different systems are collaborating, talking to each other, while EMR is like a single instance at a hospital or clinic level, which is basically showing medical record of a patient, rather than EHR, like a different records in a more cohesive way, connected way. So EHR and EMRs are very important, and I think Pakistan is lacking behind in usage. While in the COVID era, we have seen in West, like the older doctor with the senior doctors, they were not really using EHR because of their lack of usage of the technology. But after the era, we have seen that the senior doctors actually are more ahead of, like more advanced than the junior doctors in the use of electronic health record. So basically, these are to access patient data, get the lab results, communication between doctors and patient, coordinate patient care through different systems, apps, and then streamline. All the records are streamlined, and with the financial information is streamlined. And one of the new input was that how we can basically build a record which can guide the doctors how much financially they are putting an impact on the patient, especially in private care. It is very important to know so that patient is also updated in real time. We saw that the Harvard Medical started how these electronic medical records are in real time shared with the patients, which was a new in 2014. They started this initiative, which now has been taken by many of the providers around the world, that when they are writing, a doctor is creating a medical record, basically it is shared with the patient with some unique areas which are not shared, but most of the record is shared among the patients. And then it gives a lot of advantage to patient itself to correct or to add to that particular record. So it's like a more like a collaborative approach, which is more of a social approach in treating patients through a very robust electronic medical record. You know, doctors been like always saying that this record belongs to them and nobody has access to it. But that imagination, that idea has changed now. Giving remote access is an important aspect in it, that when you are at home, how you can access patient record for an emergency or something and can decide about medication or even treatment, change the treatment options, or even can review the patient from a distance and can decide about the patient. Privacy is an important aspect. Automating processes in this is again another fascinating work, like without human intervention, things can be done. And then interaction of this EMR, EHR with the different apps like patient portal, how the patient generated record can basically add to that workflow. Let me show you a record which we created. Let me see. I hope my screen is visible to all. May I know if my screen is visible? Sir Mulazim Saab, can you tell me? Is it my screen is visible? If anybody can share this with me, say. Okay. So basically, if I log in into electronic health record, something like this will show. This is a demo system. This is not a hospital. And it is running at a very low bandwidth from a server. It has admin dashboard, bed allocation, billing setup. I think many of you may have seen these systems, but this is a complete cloud-based online from a secure hosting. And maybe if I show you a consultant module, which is a doctor module, how it will look like. So basically, case count, this is patient bill information, allergies, infection, vital signs, diagnoses, and all of those. So the list will populate here. doctor will click on that particular patient and then start adding the information of that particular patient. And the beauty is, like in recent, in last 3-4 years, a lot of these health records are voice enabled. So you don't have to type in every detail, you can just say words and those information can automatically transcribed into text. So voice to text enablement is one of the key features in these, though sometimes it is difficult, but and then there are short codes, like you say something and then the whole sentence get typed, or you type something like a short code and then the whole history part is typed automatically, and then doctor can edit those things. So let me go back to my presentation. So that was an EMR. IoT or IOMT, Internet of Medical Things or Devices. So basically these IoTs, a lot of you may be aware of these, has like sprung from 2015 onwards in a big way. Like by 2020, there are about 70 billion devices, more than 50 billion basically devices are connected. So we are, and then we are thinking, we are envisaging that about 20 devices per person will be there in near future. We already carry like one connected watch, phone, maybe some other device we have in our pockets. So we feel that in the future, there'll be more gadgets connected, shoes connected, clothes connected. All of these will be connected in future. And they, by another 5 years, they will cross about more than 300 billion devices connected. And when we think of these connected devices and we connect with the environment, our home care, home-based devices, and then healthcare devices, and all of them giving us the idea of the total movement compliance of the patient. It's a great way to improve healthcare. So these devices basically have helped in reduction of the cost. We know that cost in medicine, cost in patient viewing, and the reduction in error. So error in healthcare is a big thing, and using these devices, basically automated entries into the system rather than human entries, they have reduced the error, improve patient experience. So now patient don't have to call, come to the hospital, they can remotely do these, reduce hospital admission and readmission. We can diagnose diseases faster. Even just from the processes, we can diagnose what possibilities are there rather than doing a lab test or doing a diagnostic like CT or MRI. We can basically pick these from these insights over time and plot the data and pattern recognition to view what probably the diagnosis. Better drug and equipment management. So a lot of them, and some of the examples are here: asthma or COPD based poor air digihaler, Pro Air digihaler. So this Pro Air digihaler, you may have seen, some of you may have seen that Asthmopolis was a quite like a 10-year-old concept that an inhaler is basically fitted with a device. So when somebody takes a puff, it is recorded, the location is recorded, what was the quantity of the ingestion, what time was it, who was it, all of them. And then if we plot that over a graph, we can see which area of that which are more people are taking. So we can preempt that probably there is an increased pollen or some other allergy is coming up, or this particular patient has certain increased usage, like if he's regular taking. So doctors can remotely intervene, or health professionals like medical assistant nurses can intervene and call the patient in advance to prevent the progression of the disease. So this Pro Air or Propeller Health, all of them, they have, both of them, they have this connected devices. Diabetes management, we know Medtronic, Abbott, they have like now a patch which you just stick to your skin, and you have a device you hold, bring close to it, and it will show the recording of the reading without even like a pricking. So there is a small pin in it which pricks one time in the skin and then keeps that particular small gadget on your skin, and you just touch the device and it will give you immediately the reading. So you have like multiple readings. These are plotted over time. You have best chart in the world for diabetes. Medication management forms, right? There are pill containers now, which basically will prompt the patient through their phone that there is a time to take the medication. Once they take the medicine, they open the lid, then the system records that patient has opened the lid of the medication container and has taken the medicine. Health monitoring, we have all of these devices, which may have many of the hospitals, even they are connected, like ECG monitors, saturation monitors, blood gas monitor, all of them are connected. They can even from home. So there is a new concept like hospital rather than hospital. So a lot of these hospitals are coming up in the world where the even like advanced disease management can be done from home with the connected devices. Elderly care, so fall detection, or like lying down patient with bed sores, that whether the pattern is changing or not, all of them can be remotely managed through these devices, these sensors which are fitted on the patient to get this information. Ingestible sensors, I think these are quite old. We know that these ingestible sensors, we can take graph, and these are quite old concept now. So all of these IOMTs basically help to improve the healthcare. Health data. So we are basically in an explosion of data. So you just imagine that when the human were taken to a moon through that Apollo, and then they had only a data of a iPhone 6. Complete technology was iPhone 6 level technology. Today we carry like 4 times, 5 times of that iPhone 6 in iPhone 10 and onwards, and all of these Galaxy phones and different phone models, they are like supercomputers today, which were like 25 years ago, we used to spend like 300 millions to build that data center, which we carry that smart computer or machine or a data center in our hands. So similarly, that data has actually helped, that data has impacted the healthcare. Imaging is a big way where the data is grown tremendously. Today, the total healthcare data is 2.3 petabytes. Like it's a huge data, which, and we think that the data, basically the Cleveland Clinic CEO, he says data will grow by every 2 to 3 months, it will double. And every imaging, CT, MRI, ultrasound, most of it is ultrasound or CT and MRI imaging related data, which is building in healthcare. And in my experience, even like my team used to ask me, Mubbashir, can we delete the data of those expensive storage devices we have, because we have to buy new storage devices? And I used to say, no, this data has insight. It has records, so we cannot delete this data. Then 80% of data is unstructured data. And unstructured data, through the artificial intelligence today, we can pick a lot of insights. I hope my slide is visible. So the data science, the data itself is growing tremendously in healthcare, and we are learning new things from this. Hospital portal, doctor portal, very important aspect of it, that hospitals should have their robust portals, and it is not possible for a hospital or doctor to launch their portal and overnight become the front runners of running at a perfect way. So I suggest all of the doctors should have presence of their individual presence online with some portal to connect with their patient, connect with the hospitals. And it's a great way for hospitals to connect, to automate processes, even like to avoid losses, like patient missed the appointment. So if you have a proper portal, you can basically create automated responses to patient to remind them about their appointments, their billing, their registration before coming to hospital, waiting for queue to fill in the form. They can online fill the form and submit, and these onwards can be connected to their internal systems like EHR, EMRs, or financial systems and other systems to help the patients. Artificial intelligence in healthcare. So we basically know, like we are in fourth revolution, fourth digital revolution, or 4R we call it. So industrial revolution 4. So in this industrial revolution, when we are into the age, it's a fourth industrial revolution is basically internet, age of internet after 1980s. But now we are, and that was all first machine age. We are in a second machine age, which is about artificial intelligence and machines. So robotics has really tipped off humans, and humans are basically now secondary to machines are leading the world. So in healthcare, we have a lot of robotics. We have like automated machines which are used in pharmacies, in labs, to do labs automatically. Even they have taken up that machine has used to be just like a physical arm, now has a mind of its own. So as I earlier said about Watson Health, I launched the Watson Health, and Watson Health for oncology. Basically, you just say that this 35 years old male had this lump somewhere, and then just say like a 200 worded history of it, and Watson will say, give me this, tell me about this, do these investigation. And then you don't even just have to like do the investigation, upload the investigation. Watson will itself read CTs, MRIs, ultrasounds. You do not need a radiographer to basic radiologist to read those. They will interpret those, then give you the like, what are the recommended treatment options? These recommended treatment options are not just based on the, because SMK Sloan Memorial Kettering was the first hospital worked with the IBM to come up with the recommended plans for the oncology related treatment options. But now these treatment options Watson has, which are machine Watson related recommended options over the year, when these different hospitals around the world have used, and they have input the data. So data basically improving that option of treatment options. And we see, like when we were using, we used it in 5 hospitals during my time with the KPJ Healthcare. And when we were using, basically doctors were telling me that like we are replacing the doctors, and they were afraid that this Watson is going to replace them. And I used to say, no, this is going to help you. How are you going to have that like 15, 20,000 of different medications, 100 diseases? How are you going to remember all of that data? You need health machine. You need mind health, help from machine, and help from like machine-based mind to guide you. So one particular patient was ruled out against, say, 10,000 similar cases in it. And then the system will give you the idea that what are the options available. And it greatly improved. There are many examples that all around the world, how patients are properly treated, avoiding pitfalls of the oncology related, like we go do a lot of concoctions to treat, and then there were more specific treatment options provided to these patients. So similarly, there are other AI related providers like Path AI, which basically reads the slides and images. Ibm Health, which is a symptom checker with the chatbot. So you basically just talk with the symptom checker, and it will give you the idea what probably is with the patient. Analytic, which basically reads all the unstructured data and provides insights to doctors and healthcare providers. Freenome, it's a diagnosis and blood works. It automatically reads those. Zebra, and there are many actually out there today. Genomics, again, a fascinating area. And like we know, in 2003, we decoded the first DNA, and then we had 2,000 genes and 3 billion of DNA base pairs. And how this is like, it is beyond a human to get this particular information and write on a paper and think to come up with a solution. Impossible. Like maybe even 2,000 doctors who are experts in their field, and they think they can decide about the fate of the patient through the genomic information just by reading and remembering and deciding, it is not possible. So this genomics in healthcare, ever since it used to be, one gene testing used to cost a couple of $1,000. Today, we are getting it in like less than $200. By next 5 years, it will be $10. And these machines will be prevalent everywhere, like Beijing Genome Center, which has more than 1,000 of these machines, these DNA testing machines who come up with the gene, and they have this record and drug discoveries and research and a lot of these things. And then we had the CRISPR-Cas9. So this gene editing software, gene editing system came through, like how we can edit the gene and repair the DNA, and more than 2,000 diseases can be corrected through, especially the genetic diseases can be corrected through. And we see there are social implication, regulatory compliances. That's where much of research is basically hidden and not shown, but we know that the genetic crops and genetic animals and birds were already in the world. So maybe genetic babies were tried by some of the doctors. And we know about the Glybera and Kimbria. So Glybera was the first pill to treat that genetic disease where there is this enzyme was missing, which causes the pancreatitis and pancreatic cancer, and which used to cost 1 million. I think recently they have now closed the Glybera. So it's just a research project now. And then Kimbria for acute lymphoid leukemia, especially below 25 years in neonates and in youngs and less than 25 years of age. $500,000 treatment, which has 100% of cure. And if not cured, they have the money back guarantee. Kimbria by Novartis. So it's like a genetically modified treatment. It's like a infusion given to a patient, and 100% cure is given. So there are more than 250 of these drugs now available. We know biosimilars, like these are pharmaceuticals of future, which are genetically coded drugs. Like you do not need to take a paracetamol in future. You will just need some code to help you get the reduction in fever and all sorts of other. So digital medical education, let me jump to it. So 3D, so another thing was 3D printed and 3D printing. So I worked with the Materialize here, and we had a MaxFax work with doctors here and help them to do impossible surgeries on face, scalp related, like they used to take hours to doing this, putting the titanium scalps over the craniotomy patients, which were basically replaced by like already created, printed based on the patient's CT MRI, and which will take only 30 minutes to implant it on a patient. And many of these surgeries, many of it, like even device creation was done on 3D printing. So you do not have a device, you can print a device. Trachea was basically printed to save life of a patient. So many of examples basically. So the medical education, let me take you to one of the medical education application, which we have started. So we basically started working with the university here, and we have a medical education, it's like assessment based system. So they can basically create an exam. So they say medical, this is module coordinator, put an exam name, date, time, hour, and what type of questions they want to. SBQ is single best answer question, true, false, extended matching question, which is very tough routine and you won't find much material on it. SEQ, problem-based question, OSCE, OSPEs, mixed type, basically in one exam, you have all of them. Then there are templates sent to a group or a year. So testing, like you can have many templates of it, like instructions, you just click, and then you have negative marking, you have positive marking, you can shuffle the questions, you don't shuffle the questions. So like two students may not have similar questions, so they can't do the cheating. And then you enable the previous button, they can go back, they cannot go back, all of that. And then this particular model, so we have a proper process defined in it. And let me show you, maybe if there is a possible to, let me see if I can show you a demo test. I hope I'm audible and my screen is visible. So I basically changed and already, so this starts on a time, and then student can read the option. So basically this is single best answer, another single best answer. So I'm just giving you quickly. So basically this will tell the student attempting, like number 3rd, they are attempting, no skipped, unseen 6, 2 answered. So again, I'm answering. And this is developed by us. True, false, don't know. So जी सर।
Not visible. मुझे unmute कर दें.
मेरी screen is not visible. Let me see. Share. I hope it's visible now. If anybody can tell me. Is my screen visible? Yes, thank you. So basically earlier I showed that how to create an exam. So we have a proper university developed system. So module coordinator, if he is creating an exam, just give the exam name, date, time, when the exam will start, how long is the exam, how many hours and minutes in exam, and allowed minutes. Like this exam, they can enter into this like 10 minutes before, half an hour before, or after that they cannot enter. And we have single best answer question, true, false, EMQ, extended matching question, SEQ, short essay question, problem-based question, OSCE, OSPE, mixed type has all these four. They can pose this to a group or to a year, complete year, say 200 students in a year. With one single click, they can pose the exam. They can select the group here. The templates are what instructions are given, so you don't have to type every time. Then you have negative marking, no negative marking. You can shuffle, you don't shuffle. You have like the ability to progress the exam and this. So after module coordinator, in progress test, basically it goes to the clerk, and clerk puts in exam, he writes exam, and we have a proper vetting system, how you write the exam. We have like a question bank system in it, and I think that's for more detailed discussion on this, but I'm taking you through the student, how the student marks these questions. So earlier I was at the single best answer question. So basically from single best answer question, student can view. Student can like take one question and then they can read, and they can mark from here. They can see they are attempting, they are skipped, they have skipped if any, they have unseen, they have answered. And now let me go to question number 5 and quickly. So basically if I mark this and go, and then if I go to number 7, which is I think short essay question. So if I'm typing, it automatically saves. So it automatically saves the answer, so you don't have to be worried about it losing your type data. And then if I go to save and next, and I submit my exam, submit answers. So these answers are submitted. So similarly, we have like the result, how we want to show the result and all of the stuff. Let me show you a result. So basically, here we have so if I can view the results, so this is a testing system, so I can view the result of the students. So I can see category wise, I can see subject result wise, so I can see all the results, and then I can announce the result in summary where only the main area of the result is seen. Let me show you how it is. So if I view the detail of this particular student, I have the single best answer question, true, false, so result is visible. All the questions, so I even can see the detail of the result. How were those questions done? So if this was wrong, so this was answered wrong. So we save every single detail, correct answer. So basically one can do the audit trail of these exams and then can build more analytics, more image, more patterns of understanding and how to, and then we have analytics. So a lot of these assessments, they have this difficulty index, discriminatory index, Chromback alpha, and then some other of these indices. So we have all of these indices. Basically, there is not much of a result, but if we have a proper result, So these indices are automatically applied. So with the one click, one can get a proper index of it. So because there is not much data in the system, so I actually failed to show you. So you see, yeah, so so I think in the interest of time, I quickly skip to the next. So let me show you, let me quickly close this off. So let me take you back to my presentation. So new share. I hope my slides are visible now. So we also created some games in it. So this is a drag and drop game, puzzle game. Puzzle is basically a jigsaw puzzle, hangman and word search for medical. So this particular game, I'm really fascinated by it. Like you read a sentence or you read a para, and then you say start the game. And once you start the game, some of the, like when examiner is creating this, they can say, please hide in the testing mode. So when they hide this, so they become like tiles of it. So you drag the tiles and put at the right place. So we can ask the students to read something, then test your imagination, whether you have understood it. And once they drag those and then they submit the results, so basically they can see that they have entered those particular information in the right way. So this particular automated testing is beyond possible. It's impossible to do this in real, like a paper-based environment. You cannot see whether the student has done this or not. So we have this, we even have like ladder and snake game developed into, so at every step of it, student gets a question. So when they are going to the next day, so we basically try to gamify to improve, like they have a attempt a question, they ask the question, we have word search. So basically they can search the word. Here they have searched the liver, they can search the, let me clean. Like they have corrected, so they get the marks. The Hangman test, basically they have to tell based on the right ventricle is a chamber, so the statement they have to guess what is the correct phrase or word which is asked here. So once they correct, then the person doesn't get hanged. Now the answer is wrong, so it's the person is hanged. We call it Hangman test. We have jigsaw puzzle, so you can pick any image, and that image can be broken into jigsaw based on the difficulty, 4, 8, 16, 32, any number you want. We can basically create that. So then students have to basically put that puzzle in the right. So this is how we say difficult images can be remembered through this. So once the student has the right image here. Let me show you one of the new share. Let me take you to a new share of it. So you see this particular video, which is an interactive video, which we have in our system. So now the superior vena cava receives the blood from head and neck, chest, upper limb. So if I check, so I continue. So basically, while watching the video, we capture the student's response, and then we basically can tell the student whether they have to repeat watching, how many times they continue, all that algorithm we can develop. And so now it's a true false. Continue. So basically you can see that I'm playing this direct from YouTube. So in our system, you just have to, anybody's YouTube video, you just take that shareable link, put it in the system and put the questions on top and share with your students. And then the beauty is that we have all the data of each individual student captured in our system to tell whether, so basically this is like fill in the blanks. Continues. So So this is basically drag or drop. Yeah, or fill in the blanks. So continue. So this is another great way of helping in COVID time, helping universities to improve the knowledge sharing and testing the students, whether they are really paying attention to their work or not. Okay, so let me go to the third part of my presentation, which is on telemedicine. My screen is visible. So basically, telemedicine is quite an old concept. So through the, like in Malaysia in year 2000, they had a huge investment to build, like connect remote cities, remote villages with the main cities, tier 1 cities, to get the knowledge about patients' health. Initially was for like just discuss on the phone, followed by with the video consultation. And even I visited a telemedicine center in the US to see how these centers work and bring that technology to Malaysia. And Cisco's headquarters in San Francisco, I viewed the Cisco. Cisco is very advanced in networking. So how to ensure that the proper speed and image quality and lossless technology is there. So it saves time and energy and money in it. So every dollar spent, like every $5 spent, if we use telemedicine, we can save $1 out of every $5 spent. And then we recently saw that Teladoc is a unicorn, more than $1 billion startup in US, worth about 40 billion today. And sorry, let me, so more than 40 billion. And then we saw now the Teladoc related, they have more than 15,000 studies daily. Like before COVID, they had like just like less than 1,000 studies a day, which has now gone up to, I visited Kaiser Permanente headquarters, Oakland Medical Center, and they told me in 2015, that by 2015, they had more online visits than inpatient visits at the Oakland Medical Center in San Francisco. So you imagine even before COVID era, these were there, but after the COVID era, this has really gone huge, and we see that 15% annual growth, compound annual growth in revenue is expected every year onwards from 2020. And this industry is going to be $250 billion industry. So we, like in Pakistan, I feel if our doctors are connected online, we can provide treatment options, diagnostic options, all those facilities to whole of the world. Basically, we can export our services through use of this technological medium and help. Let me show you a system which is Ambra Health, and which we are in collaboration with, and I brought this system to Pakistan in 2019 in a conference, and we can basically use and provide this system to doctors in Pakistan. Ambra Health is basically a PACS related solution, which is vendor neutral archiving for the PACS. So you do not have to like specific to a DICOM machine or a modality, CT, MRI, any MRI, CT, we can connect it. It does not require any of those old mediums. It is interoperable and value coded a lot. Let me take you to the Ambra Health system, sharing the screen. So I'm logging in as my ID into Ambra Health. So you see this, like in this, I have studies, which are, these are CT chest. So this particular CT chest, so if I see the images of the CT scan, so this is somewhere else in the remotely in the cloud, and I'm viewing on my simple machine at a home-based internet. So I can basically, I can roll my mouse and you see all the CT I can remotely view. I can zoom it, like zoom this particular, so I'm not good at, so you good at this utilization. So I can zoom it, I can move it, I can rotate it. So levels of contrast, I can basically define, I can different levels, pixels, I can bone setting, I can define palettes, I can work on length, I can work on angle. And so all of these, like if I close this, and if I want to upload an image, so if I say study and upload a study, So I just pick any of the stored data in my machine, CT, MRI, and amazing thing about this Ambra Health, that even if you have a simple phone-based connectivity with your machine, you can upload CT, MRI, all of these. Like maybe, let me show you a PET scan with a contrast, and very tough study to be done of a PET can be done here. This is a PET. So now it's picking all the PET through remote. So I can basically view the PET scan, and this, the hanging protocols and the colored protocols, all can be done through this big. I'm a little bit like not that expert on this. So this is a great example how teleradiology can help. So in telemedicine, basically like in US, there were less than, in Johns Hopkins, there were less than 100 doctors registered for pre-COVID era for this telemedicine related sessions. After the COVID, more than 2,000 doctors in Johns Hopkins have registered themselves for telemedicine related health options. So more and more doctors are coming into this, and technology is not that poor anymore that we cannot do. We can do all sorts of workloads like skin. We have zoom in cameras. We can view the skin lesions. We can tell, we can we can listen through stethoscope, which are digital stethoscope. We can do that. We can talk to the patient, share the knowledge. We can do follow-ups. We can share the screen, explain these phenomena better to these patients rather than they are sitting next to us. And when they are actually looking at the screen, we can do. So there are things which can be done better in telemedicine, which are in conventional ways we can't do that good. So I think I've taken a lot of time. Let me finish this here. I had 1 or 2 slides more. Let me go back to my slides, which is like to talk about like recommendation. So we need like for, especially for Pakistan, I suggest the universities, institutions, doctors, they should build together. They should collaborate with each other. Then at the national level, university level, higher commission level, they should have policies of it, how to help incentivize, provide impetus to these. And then we must set budgets to help roll out these in a better way. So I think, let me end it here, and I'm open for any questions. Thank you so much. And my last slide was a view of Pakistan. Thank you so much. Over to you, sir.
Dr. Mubbashir, thank you very much. Really, it was a brainstorming and very difficult to understand, but really interesting. The first question is from Professor Bilkesh.
Listening to your talk, I was reminded of a movie which I think watched when I was in class 5 in 1985. It was a USA movie, Back to the Future. And Back to the Future 1 led you 30 years back. And the sequelae, there were 2 more sequelae, and one of the sequelae led you 30 years ahead. And I've seen many of the things watched in that movie are, you know, a thing of commonly seen nowadays. And one of them are these holograms, and it was something very, you know, what we are doing right now is nothing less than a hologram. It seems as if Dr. Mubbashir is sitting right in front of me, and I'm listening to him, and, you know, he's sharing his experience even more than what we saw in Back to the Future. And I think what COVID has done is that that it has, you know, moved us to the future within 2 years. Especially in Pakistan. We were totally naive of the telemedicine in Pakistan till the March of 2020. I think that was when, you know, especially in Punjab, it started off in Punjab by the initiative of Governor, as I talked about last time. And sir, I was really, really impressed by your talk. There were different segments, examination of the students, examining a patient, and telemedicine. I would require your special expertise if you could spare some time for telemedicine, especially how can we improvise. Thank you so much. Sir.
My pleasure. Thank you so much.
Dr. Muhammad Nadeem. Dr. Muhammad Nadeem. Qazi sahab inko unmute kar dein. Dr. Muhammad Nadeem want to ask a question.
Okay. Am I audible?
Ji, audible.
Ji.
Thank you very much, sir.
First of all, I would like to appreciate a very nice presentation by Professor Mubbashir. My question to you is that I was very impressed by the way you demonstrated the conducting this MCQ-based exams. My request to you is, I was interested in conducting this OSCE or OSPE online. Would you comment on it? I'm just interested to know that how you are going to conduct this interactive OSCE online. Thank you.
Yeah. So basically the OSCE which we discussed with the university is based on, like, it's not fully developed yet. So they basically define the exam, and then they say there is a live camera rotated to that, and the person who is remotely viewing it on that, and then the person can, the examiner can discuss with the student through remote, and they can watch. So in our exam system, there are actually so many things which I haven't shared here. We have a live, like a Zoom type of system, where you have a video camera built in it, which you can rotate. So while doing the examinations, if student is doing, so there are 2-3 examiners, they can remotely watch student. So if he's on a mannequin and he's doing something remotely, people, they can watch. Even we had like specimens and all those. So this student gets a specimen which is in remote, like, or even a mannequin which is in remote on image, and then this student can do the gesturing, and then these gestures can be picked through remote and can be given. So it's not like a really replacing the real OSCEs, but at least guiding students to learn properly.
Thank you very much. Dr. Masood Javed is here. Dr. Masood Javed, you are related to the research and medical education. Can you ask the question, Dr. Masood? Sir, can you unmute Dr. Masood from Karachi? Okay.
He can unmute himself.
Ji, Dr. Masood.
Yes, hello. Can you hear me?
Oh, yes.
Yes, sorry.
Can you hear me?
Yes,
Yes, we can hear you. Please go ahead, sir.
Yes. Thanks a lot. Thanks a lot for excellent opportunity. It's very nice to listen about AI and other aspects, and also in education as well. So as you have discussed about OSCE, so what is your experience of doing OSCE by using the Zoom platform, by using the different rooms, breakout rooms, and then shifting over to the students in one by one in the examiner, and also your experience or some comments about in many universities they're using, because it's a distant, even there is no on-campus examinations and OSCE, so they use their relative, some other person to show them the examination technique, and the examiners are giving marks on the student based on what they looked into in the breakout rooms. So just a comment or your expertise in that area.
Yeah, so with the university which we are working with 2 universities. They also use Zoom and other video related systems to do these type of simulations, but they still are not really impressed with it. So you need a lot of like devices to zoom in, zoom out, like proper gadgetry to do these OSCEs. So on top of Zoom, you need a lot of devices to help with it. So, but at least it can guide. It can guide the student, and then the examiners who are in remote, there are difficult procedures. So it is a good way at least to do certain percentage of teaching through OSCE.
Okay,
Dr. Hussain Baksh Kulachi.
Mulazim Sahab, Dr. Qazi Wasiq, I just want
yes,
to...
sir. Yes, sir, Qazi Sahab.
नहीं अगर
Sir, Assalamu alaikum. It was a nice presentation, and my question is how preventive care can be promoted or given to the rural and majority population in Pakistan through this digital healthcare technology. Thank you, sir.
Yeah, I think like doctors has to start using technology. Once doctors, they start using technology, then there should be some policies that they should be helped with it. And then the patients can start coming to those clinics which are remotely connected in area. So like maybe at the divisional headquarters, we have a specialized area where we have remote facilities where doctors are sitting and treating areas of that particular division headquarters. So absolutely, this is the way to go ahead in the future. As I was like, when doctors, especially like Pakistani doctors, can meet together to build a collaborative approach to offer these services to the world. So they can combine and whole world can be their village. So then, but in Pakistan, certainly if the bandwidth is available with the phones, you can talk to it. You imagine Babylon Health, they have this app where patients can talk to the app and I have headache. Then what is next in it? We can build a similar app in Sindhi, Urdu, Punjabi, our local languages, and then people talk to it and then they get some idea that you need to talk to a doctor or you probably need to take medicine. So it's like so many options are there.
Dr. Mubbashir, my last question.
मेरी कुछ बात अगर इजाजत हो मुलाजिम साहब, मैं थोड़ा सा मैं टेली हेल्थ जो है पाकिस्तान में डेफिनेटली इस्तेमाल में ज़रूर है, और इसकी हिस्ट्री पाकिस्तान में ये है कि 2001 में कॉमसेट्स ने गुजर खान के अंदर पहले टेली हेल्थ क्लिनिक बनाया था, उसके बाद इस करदू में, और इसे एज वो लेके जा रहे थे बेसिक हेल्थ यूनिट्स तक। और इसमें सबसे बड़ा बैरियर जो आया है वो ये कि डॉक्टर्स जो हैं दे आर नॉट इंटरेस्टेड इन आईटी, और उनकी जो नॉलेज है इसमें और वो सीखने को भी तैयार नहीं होते। और फिर जैसे डॉक्टर मुबशिर ने कहा कि डॉक्टरों का ये ख्याल है कि शायद उससे उनकी प्रैक्टिस जो है वो कम हो जाएगी या कुछ उस पर इफेक्ट पड़ेगा, और इनफैक्ट बिल्कुल सही बात की डॉक्टर मुबशिर ने कि इससे इनफैक्ट उनकी जो स्किल्स, उनकी पेशेंट क्लाइंटेल, ये सब बढ़ेगी। और पाकिस्तान में जहाँ 70% आबादी गाँव और देहातों में रहती हो, वहाँ पे हमें अपने जो प्राइमरी हेल्थ केयर है उसे इसी तरह मैनेज कर सकते हैं कि हम इसको टेली मेडिसिन पे लेके जाएं और ये वर्चुअल कंसल्टेशन पे लेके जाएं। डॉक्टर साहब ने टेली मेडिसिन के हवाले से रेडियोलॉजी का बताया, लेकिन पैथोलॉजी के अंदर इसका बड़ा रोल, जनरल मेडिसिन के अंदर बड़ा रोल है इसका, रेडियोलॉजी में तो है ही है, स्किन के अंदर है, गायनी में है। आई एम एन ऑफ्थेल्मोलॉजिस्ट and we are using gadgets which are very cheap. I mean, we have our smartphones adapters which can be attached to slit lamps or eye ka total examination, interior segment examination and the retinal examination. We have been conducting these teleophthalmology clinics, और हमारा जो बेसिक हेल्थ यूनिट में जहाँ सिर्फ एक medical graduate बैठा है, he can have access to all the specialists, और specialists की advices उसे वहाँ मिल सकती हैं। अच्छा, दूसरी बात जैसे बात की, अब तो बहुत सी गैजेटरी और बहुत सा हार्डवेयर अवेलेबल हो गया है, और वो वक्त दूर नहीं जब हमारा ये स्मार्टफोन जो है ये स्टेथोस्कोप है, इसका जो चेस्ट पार्ट है वो पेशेंट का मोबाइल फ़ोन होगा, और जो इसका हेडबैंड है जो हम हेयर करते हैं वो डॉक्टर का स्मार्टफोन होगा। अच्छा, एक और बड़ी इंटरेस्टिंग डेटा है यहाँ कि पाकिस्तान में तकरीबन 180 मिलियन फ़ोन यूज़र्स हो गए हैं, सब्सक्राइबर्स, जिसमें से जो कि 90% ऑफ द पॉपुलेशन है, जिसमें से तकरीबन 50% या 45 to 50% स्मार्टफोन यूजर्स हो गए हैं। अब 3G और 4G की नेटवर्किंग अवेलेबल है, तो फ्यूचर जो है वो यही है कि टेलीमेडिसिन, टेली हेल्थ। अच्छा, एक और मैं बताऊं कि यहाँ बहुत से इदारे जो हैं टेलीमेडिसिन और टेली हेल्थ कर रहे हैं, रन कर रहे हैं, बहुत से प्लेटफॉर्म्स और पोर्टल्स हैं जो कि डॉक्टर्स को और उनको ये फैसिलिटी देने को तैयार थे। लेकिन मसला यहाँ पे ये आता है कि जहाँ फाइनेंशियल इम्प्लिकेशंस आती हैं, यानी एक डॉक्टर जो है इस टेक्नोलॉजी के ज़रिए से अपना प्राइवेट क्लिनिक भी कर सकता है, उसको पेमेंट्स भी आ सकती हैं ऑनलाइन, لیکن وہ یہاں ابھی کامیاب نہیں ہوا. لیکن ای ڈاکٹر, ایجوکیسٹ, جنہوں نے 1000 ڈاکٹرز جو ہیں وہ اس پہ یوز کیے, اور تقریباً 27 ممالک میں ای ڈاکٹر جو ہے وہ ٹیلی ہیلتھ کلینکس رن کر رہے ہیں. تو پاکستان میں ڈیفینیٹلی یہ اب ضرورت اس بات کی ہے کہ ہمارے ڈاکٹرز جو ہیں اپنی آئی ٹی کی نالج کو بڑھائیں اور اس کے اندر جائیں, اور اس بیریئر کو جو ہے وہ ختم کر سکتے ہیں. اینڈ آئی تھنک اٹ واز an excellent presentation, very enlightening. Thank you very much, Dr. Mubbashir. I think اس سے مجھے لگ رہا ہے کہ آج بہت سارے لوگوں کو آگاہی ملی ہے. I've been doing a lot of courses in IT and I'm involved with the IT things and یہ gadgetry اور اس میں, تو میں سمجھتا ہوں کہ بہت جلد وہ وقت دور نہیں جب ہمارے ہاں ٹیلی میڈیسن جو ہے ویری افیکٹولی یوز ہوگی, اور اس ملک کی ضرورت ہے. Because of our rural areas, ڈاکٹرز کی وہاں کمی ہے, اور اسپیشلسٹ اسپیشلی ان رورل ایریاز میں نہیں جاتے. So it was wonderful. Thank you very much.
Thank you very much, Ali Saab. Now,
Thank you, sir, Dr. Mubbashir or Dr. Wajid. Thank you.
I think now, Madam Salma, can you ask any question or gain any comments?
Haji, it was a pleasure listening to you, Dr. Mubbashir, and
Thank
I
you, madam.
thank Bukhari Saab, and I thank everybody who's attended this meeting, especially Qazi Saab, because of the PMA, he's handling the affairs at that end. I have a little statement to make on behalf of PMA and Mulazim Saab being in charge of a medical college, and even Bilki Saiba ko main kahungi ki hum यूं करते हैं, PMC के लिए एक letter draft करते हैं, हर एक चीज के उन्होंने hours रखे हैं. इसमें IT की भी students के लिए hours रख लें, ताकि after 5 years when they get their degrees, they are trained in telemedicine. क्योंकि otherwise when they become graduates, फिर इनको train करना जरा मुश्किल हो गया है. We have a hospital and we have this electronic medical record in it, but we are getting problems from the nursing staff and from the doctors. They do not enter their notes on the laptop. Although it's very easy to use a laptop, but if we train them in these 5 years, unke liye it would be very, very easy, and maybe they start enjoying it. So I think that's a good idea. Let's contact the PMC. और इसका एक पक्षी जिस तरह उन्होंने hours delegate किए हैं, अभी even family medicine को दिए हैं, जिसका पहले कोई concept ही नहीं था, वो 100 hours दिए हैं. उन्होंने self directed learning का 500 घंटे दिए हैं. मतलब उन 500 घंटों में से अगर वो 300 घंटे IT की तरफ दे दें, टेलीमेडिसिन की तरफ ले आए, तो it will benefit our new generation. Thank you so much, Dr. Mubbashir. I thank you once again. Thank you, everyone.
कैसर सजाद जी काजी साहब.
मैं मेरे ख्याल है कि यहाँ बड़े सीनियर हमारे प्रोफेसर्स और वो बैठे हैं. मैं एक और कमेंट करना चाहूँगा कि ये जो टिकटॉक जो है, मैं समझता हूँ इट्स अ ब्लेसिंग कि इससे बहुत से लोग, इवन इलिटरेट लोग भी स्मार्टफोन हैंडलिंग और उसको इस्तेमाल करना सीख चुके हैं, और बड़ी ज़बरदस्त किस्म की वीडियोस और वो बनाते हैं. तो स्मार्टफोन हैंडलिंग एंड लर्निंग उनको आ गई है, इवन इलिटरेट्स. तो इसको अब हमें ट्रांसफॉर्म करना है कि इस लिटरेसी को हमें हेल्थ सेक्टर के अंदर लेके आना है, कि ये जो टिकटॉक ने जो इनको ट्रेनिंग दी है स्मार्टफोन यूजर्स को और उसको इस्तेमाल करने को, इसे हेल्थ में किस तरह से लें. आई थिंक वी शुड ऑल वर्क ऑन दैट.
जी डॉक्टर अयूब जी, कैसे सजाद.
हाँ जी, थैंक यू वेरी मच मुलाजिम साहब. आई थिंक इट वाज वेरी वंडरफुल और एक्सीलेंट प्रेजेंटेशन बाय डॉक्टर मुबशिर. मेरी तो बड़ी नॉलेज में इजाफा हुआ है. एंड आई थिंक डॉक्टर सलमा जो हमारी प्रेसिडेंट पीएमए हैं, उन्होंने बड़ी जबरदस्त बात की है कि अगर हम इसमें हमारे जो बिहेवियर है और हमारा जो नेचर है वो यही है कि जब तक हम पे थोपा नहीं जाता है हम वो काम करते नहीं है. तो आई थिंक कि हमें इसको कंपलसरी करना चाहिए करिकुलम पे. एंड इट्स अ वेरी गुड, जैसे काजी साहब ने कहा कि जी टिकटॉक हम सब करते हैं, तो टिकटॉक तो इलिटरेट लोग भी बना रहे हैं. तो व्हाई नॉट this technology can be used in health sector also, एंड हमारे यहाँ तो सारे ज़ाहिर है पढ़े लिखे लोग हैं, तो इजीली वो हो सकता है। तो प्रॉब्लम इज कि सिर्फ थोड़ा सा टेक्निकल ये जो आज जो हमारी तालीम हुई है, आई थिंक इससे हमें इसको कंटिन्यूअसली करना पड़ेगा हमें बार बार, और लोग फिर इस तरफ आ जाएंगे। आई थिंक इट्स अ वेरी गुड स्टेप। आई मस्ट कांग्रेचुलेट टू यू मुलाजिम साहब कि आपने हमारी मुलाकात कराई मुबशिर साहब से, और जबरदस्त मैं अप्रिशिएट करता हूँ on behalf of the Pakistan Medical Association as a Secretary General Pakistan Medical Association. I appreciate the effort of you and Dr. Mubbashir. Thank you very much, sir.
Before closing the session, I will ask anybody want to ask, raise the hand from Zaidi. Thank you, Mubbashir. And so many comments, Dr. Mubbashir, about you. No doubt it was very difficult. कुछ चीजें तो हमारे ऊपर से गुजरती रही, but anyhow, we are really going to the era where the medical IT and digital IT is being used. Last time you told that now there is a device to connect with computer, and you can check the stethoscope through stethoscope, the heartbeat, even you can check the blood pressure. Can you lastly comment on it?
Yes, sir. So this is a digital stethoscope. These are many of them now. Even Litman has their digital stethoscope, which has like Bluetooth enablement and which can record the voice. So there are many of them, sir, out there.
When I got corona, I used to check when my pulse oximeter was my phone.
Yes.
And it gave me the same results.
Exactly. So you just place your finger on the camera at the back of the phone, and then it will give you the reading, which is quite close to the.
We have 3 minutes, Madam. Can you conclude? Professor Salma Kundi is the president of PMA and also principal of Women Medical College, Ahmedabad, and Madam, over to you.
I said before, thank you, Mulazim Saab, for introducing us to such nice people. And I really, really admired you, Dr. Mubbashir, for the knowledge that you gave us, and you opened our eyes to it. And after brainstorming, inshallah, meeting most of the people, we'll take them on board, and we'll contact the PMC so that they slash down the self-directed learning 500 hours, which is a bit too much, and give half of it to IT. And I think there should be a paper on IT, so that even during their house jobs, the students know how to use their smartphones and they know how to enter things and make the data. Thank you so much, everybody. Have a good day.
मैं 2 मिनट बात कर सकता हूँ मुलाजिम साहब? एक जुमला बोलना चाहता हूँ मैं काजी साहब अगर यहाँ मौजूद हैं तो मैं काजी साहब को बड़ा अप्रिशिएट करता हूँ उनकी मेहनत को, बिकॉज ये कि मैं इनके साथ देखा है इनको जिस तरह से इस प्रोग्राम को ऑर्गेनाइज कराने में, और सारे टेंशन में रहते हैं कि यार कैसे अभी तक मुझे स्पीकर का नहीं मिला, मैं कैसे बनाऊं, क्या करूं। तो मैं अप्रिशिएट करता हूं इनको और कांग्रेचुलेट करता हूं ऑन दिस प्लेटफॉर्म दैट ही हैज बीन elected as a president elect in CMAO. I think you all know about the CMAO, the Confederation of the Medical Association of Asia and Oceania. तो ये हमारी एक एसोसिएशन बनी हुई है जो कि हमारी एवरी सैटरडे को एक मीटिंग होती है सुबह के वक्त, जिसमें सीमाओं के जो मेंबर्स होते हैं, जिसमें इंडिया, बांग्लादेश, श्रीलंका, सिंगापुर, बैंकॉक और चाइना, ऑस्ट्रेलिया, ये सारे और लोग होते हैं जो कि सुबह बड़ी अच्छी इंफॉर्मेटिव चीजें होती हैं। तो ये आजी साहब उसके प्रेसिडेंट इलेक्ट बन गए हैं। और एक चीज और मैं मौके से फायदा उठाता हूं कि आप लोग कराची आएंगे 23, 24 और 25 सितंबर को। इस दफा पाकिस्तान होस्ट करेगा सीमाओं की मीटिंग को, हर साल होता है। तो पिछली दफा मैं वहां गया था, हम लोग 2-3 लोग गए थे हमारे साथ, निजामी साहब और मैं था वहाँ मलेशिया में, और मुझे उस वक्त तक मुबशिर साहब का पता नहीं था। तो मुझे अफसोस हो रहा है कि मैं उस वक्त अगर मुझे पता होता तो मुबशिर साहब से मैं जरूर मिलता वहां पे मलेशिया में। तो एनी हाउ वेल डन काजी साहब, आपने बड़ा अच्छा अरेंज किया। आई होप कि ये बहुत अच्छा चलता रहेगा। और वेल डन अपना मुलाजिम साहब कि आपने शुरू दिन से इसको बहुत अच्छा किया है और इसको प्लीज कंटिन्यू करते रहेंगे इंशाल्लाह हम लोग पाकिस्तान मेडिकल एसोसिएशन के प्लेटफॉर्म से। और ये सारा विजन जो था ये हमारी प्रेसिडेंट डॉक्टर सलमा कुंडी का था विजन जो इन्होंने ये स्टार्ट किया। थैंक यू वेरी मच।
Thank you.
Last but not the least, our next session will be on the radiological aspect in the how the radiology can help in COVID diagnosis and even the role of radiology as Dr. Mubbashir has initiated. And our speaker will be the ex-Vice Chancellor of Boston, Howard University, and he is also Pakistani. He is an old man, but we are very lucky to approach him, and he will give the presentation on the role of radiology. Thank you so much.